So at ESMO 2021, as a late-breaking abstract, I presented on behalf of co-authors from the EORTC a phase 2 randomised multicentre study of bevacizumab versus atezolizumab and bevacizumab with acetylsalicylic acid or aspirin or placebo in platinum-resistant ovarian cancer. So the background and the reason for this study is that, unfortunately, the majority of women eventually develop platinum-resistant disease once disease has recurred. And there remains an unmet need for more effective treatments for platinum-resistant ovarian cancer. So to put it into context, the median progression-free survival is around 3 to 4 months, and overall survival around a year with chemotherapy. And bevacizumab has led to improved outcomes in patients with 1 or 2 prior lines of therapy, but we need to have better treatments and more treatment options. So there's been a lot of interest across tumours and also in ovarian cancer with immunotherapy approaches. But the response rates to date with immunotherapy alone have been relatively disappointing. So in order to improve the responses to immune checkpoint inhibition, we need to address additional immunosuppressive pathways in the tumour microenvironment, for example, prostaglandin E2 or the vascular endothelial growth factor. And COX-2 is a key enzyme involved in prostaglandin E2 synthesis, and also vascular endothelial growth factor is very important. And this can limit T-cell homing to tumours and thereby contribute to immunotherapy resistance. Preclinical work led by George Koukos's lab and others has shown that by targeting prostaglandin E2 and vascular endothelial growth factor, we can increase T-cell homing to the tumours. And that was the rationale for this non-chemotherapy approach in the EORTC 1508 trial. So in the EORTC 1508 trial, this was designed to assess the clinical activity in platinum-resistant ovarian cancer. So the study was carried out in 5 countries across multiple sites. And initially, patients were randomised to one of 5 arms. So bevacizumab alone, or atezolizumab with placebo, atezolizumab with acetylsalicylic acid, which I'll call ASA, bevacizumab, atezolizumab and placebo, or bevacizumab, atezolizumab and ASA. So a key part of this study is that biopsies were integral, required at baseline, pre-cycle 3, and optional at progression. Treatment was until progression. And of note, patients on the first 3 arms, so the non-combination arms, had the opportunity to cross over to bevacizumab and atezolizumab at progression. What's really important in this trial design was that arms 2 and 3, so the atezolizumab and placebo or atezolizumab and ASA arms, were closed in January 2019. A decision that was made following the press release in November 2018 that showed that there was minimal efficacy of the PD-L1 inhibitor avelumab in phase 3 study in this disease. So that meant that the total number of patients was revised from 160 to 122. So key eligibility criteria include the fact that platinum refractory disease was excluded. Any number of platinum-based chemotherapy lines were allowed, but a maximum of 2 non-platinum chemotherapy lines. And patients could have received prior bevacizumab or VEGF targeted therapy in the past. As for the statistical design, the primary endpoint was PFS at 6 months. Secondary endpoints included overall survival, response rate, time to first subsequent therapy. And in each arm, the null hypothesis was that P0 was 30% and the alternative was P1 of 50%. And using this Ahern design at one-sided 15% significance level with 85% power, the decision rule of observing at least 12 out of 29 patients to be alive and progression-free at 6 months was needed to warrant sufficient clinical activity to take forward. So in this study, I'd like to point out that the first 29 patients were analysed for the primary endpoint decision of activity in the arms 1, 4 and 5, given that the arms of atezolizumab and placebo or with aspirin were closed. What's really important that I'd like to point out is that 84% had 3 or more prior lines of therapy, and almost 70% had prior bevacizumab or a VEGF inhibitor. So what we showed was that the percentage of patients progression-free at 6 months ranged from 20.7% to 27.6%. So just to remind you that we needed 12 out of 29 patients to be reaching this stage, and therefore the protocol-defined activity threshold was not reached for any of the arms. However, there are some very important other points that we needed to, that we reported on. So response rate until next treatment. So the response to bevacizumab was 9.7%. To the combination arms of bevacizumab and atezolizumab and placebo, that was slightly higher at 19.4% and 15.2% with the bevacizumab, atezo, and ASA. We did report on the atezolizumab alone arms in terms of response, and this was 0 out of 10 patients with patients treated with atezolizumab and placebo, for example. Now, progression-free survival-wise, the median PFS of bevacizumab was around just over 2 months, and for the bevacizumab, atezo, and placebo or ASA arms, it was around 4 months. So although a numerical improvement in PFS, this was not statistically significant. We also did report on time to first subsequent therapy. The median for bevacizumab was 3 months. There was a statistically significant improvement for the bevacizumab and atezolizumab and placebo arms, or indeed the aspirin arms, that was around 5.3 to 5.8 months. But we also need to remember that patients did cross over from bevacizumab to those arms. And also I'd like to point out that 6 patients were still on treatment on the bevacizumab and atezolizumab containing arms at the time of analysis. There was no difference in overall survival to date. And what's really important is the translational work that will follow. So what we've learned so far from the EORTC-1508 trial is that the addition of aspirin to atezolizumab and bevacizumab does not appear to improve efficacy. Some of the questions to think about is also whether the dose of inhibition for prostaglandins was sufficient or not, and some of the ongoing work will look into this. What we know going forward is that there is a wealth of translational work that is planned, so that we'll be looking at the tumour infiltrating lymphocytes, for example, PD-L1 expression, looking at the tumour microenvironment in the endothelium, and we'll be doing TCR sequencing and spatial transcriptomics, because one of the strengths of this study is that approximately 70% of patients we have serum, PBMCs and biopsies for. So I really look forward to the next steps so that we can learn a lot more about the biology of platinum-resistant ovarian cancer and the impact of anti-angiogenic treatment with PD-L1 inhibitors, and also the impact of COX-2 inhibition. So I'd like to thank the EORTC for sponsoring this study, and of most importance, the patients, the families, the trial teams, and the funding for this study. I very much hope that the translational analyses which are ongoing will help identify biomarkers of clinical benefit.